As we clear the stage for session 2A, what's as reflected in those sessions too, something unique about Sparked is having the states involved. And, we have by design in this session today really focused on that top end of policy reform and what at a government level and a system side. We're really starting to get into what this means in a healthcare setting. So I'm going to we're going to go around into different states, and we'll start off in South Australia. I'll bring on Mark in just a second to really hear from those jurisdictions on how they're implementing some of these solutions and what it means at a local level. So joining me up on stage here, I've got Mark Bellige from South Australia. G'day, Mark. How are you?
Peter, how are you?
I am loving it, in my element, as they say. So, yeah, as we've gone back to back here, have you? I can share up some slides, or are you going to share up your screen from there? We've got
I
iPad.
will share up my screen.
We're spoilt for choice. And while we do that, continue to keep those questions and comments coming through in the chat whilst we may not get to everything. It's been great to see Peter O'Halloran was working hard in the chat too while he was on stage and answering what he could. And that's generally the approach here. That's my reflection taken from Spark. So I'm going to hand over to you, Mark, for your presentation.
Thanks, Peter. Look, for those of you that I haven't met yet, my name's Mark Belay. I've spent the last 12 months falling with SA Health to design the interoperability roadmap and to start executing it. And for that, I've lent on my background as a hospital doctor for several years, and then a digital health tech startup founder and a CTO, which have all rolled together quite nicely. So at a Sparked event, we all deeply understand the value of interoperability. So I don't really need to convince anybody here of the importance, but I do like to kick off with this slide to demonstrate the why of why SA Health and other jurisdictions need interoperability standards. And so I have this nausea-inducing slide to do so. Patient-centered care is a universal principle that's clearly important to all of us, right? But from a data and a systems perspective, we don't actually practice what we preach. So far, in the digital age with technology, we've actually practiced organisation and solution-centred care. And that's because that's been the path of least resistance since we started in the digital age of healthcare. And so if we do put our patients at the centre, what we find is that the different parts of the ecosystem don't work together as a whole without standards-based interoperability. And in fact, they often work against each other and give rise to the kinds of inefficiency, miscommunication, expense, and poor outcomes that we all want to solve with national standards and international standards now. One thing that we can be sure of, or several things that we can be sure of, is that going forward, we're going to have more systems with more data coming online. There's going to be greater volume and types of data to share. And there's going to be many more ways to put that data to use and to share amongst broader audiences and stakeholders. So the problems are going to get larger unless we address them now in this window of opportunity that we have. So interoperability is a tough sell. Like most organisations, SA Health has a culture of project-based initiatives. Projects are budgeted, they have end dates, they've got a resource allocation, and then they're done. Now, interoperability maturity is a tough sell into that mindset, because whilst the benefits of interoperability standards are immense and they're sustained in perpetuity for as long as we can imagine, and the upfront investment's quite modest, there are many steps, there are many dependencies, and there's many stakeholders in between that make it important to treat the process as a strategic journey rather than as a set of projects. It's not as easy a sell as buying and rolling out an app. So for our interoperability journey at SA Health, we've segmented the approach into these 6 concepts, where our interoperability capabilities will take the form of the factory, and the factory builds the engine, and the engine powers the wheels. And that's what ultimately gets us through to the healthcare benefits that we're all seeking. Now, the healthcare benefits that are at the end of the journey are in the form of the quintuple aim, and we all know what they are and what they look like. And there's the added aspect, the stick, as it were, if the quintuple aim is the carrots, of regulatory compliance and accreditation. So what's the factory? The factory are our people, our processes, and our technologies. We need to assemble all of those aspects to incorporate the standards to build a platform of interoperability. And that takes the form of the engine, which is the Fire Health Information Exchange, our practice of terminology services, our ability to lift up data from our existing systems and enrich them with national identifiers and clinical terminologies to ensure we've got best practice data quality management and that the entirety of our data assets are secure, trusted, and auditable. And this is where the gap comes in that's between interoperability engines and the benefits is we really need the wheels where the rubber hits the road that are powered by the engine and are the frontline facing systems that our clinicians and our patients and our clinical researchers will use. So they're portals for those different audiences, they're digital services like e-prescribing and e-requesting, and they're enhanced pieces of automation and intelligence like AI. Now, where are we on this journey? Well, we're at the start of getting together the vision and the resourcing to maintain the focus across this journey. So we have to invest in all of those aspects to get to the end. One thing that I will take a moment just to harp on, because I found that this grabs a bit more attention, is that the regulatory requirements around hospital and aged care accreditation are now starting to incorporate requirements to use national identifiers and clinical terminologies. And so I'm increasingly starting to hear from hospitals in particular that are asking, what's our interoperability plan? Because we need to show to our accrediting agencies that we have one and that it's being actioned. So I think in this Spark community, that's important to be aware of. So current state in SA Health is that we've had and have systems of record that are incredibly valuable and resource rich, and are the systems that everybody uses from day to day. And we've traditionally integrated them through an enterprise systems bus using HL7 messaging or custom data integrations. And as of 2025, that takes the form of InterSystems Iris for Health. And so they're swapping all sorts of messages back and forth between them. And this will be familiar to all of the jurisdictions. Now, we have some natural advantages here in South Australia in that our single systems of record are quite pervasive. We've got a single PAS and a single EMR across all of our 3 metropolitan and 7 regional local health networks. And similarly for our other systems of record, like our risk packs, and our laboratory information system, theatre booking systems, and pharmacy management, and so on, they're quite pervasive. We're not as fragmented, perhaps, as some other areas might be, and that's a real advantage. And we already have InterSystems Iris in place, which can help us build that bridge from the methods of integration that have served us so well to date into the interoperability standards that we need to scale to the next level to meet future demand. We've got the national services and our HIPS middleware that is helping with source identifiers and uploading to My Health Record. And now we need to augment those systems of exchange with Onto Server as our FHIR-based clinical terminology server that will help us provide the semantically interoperable identifiers for all of our healthcare data, and to interact with systems such as the NHSD and the directory so that we're able to source the healthcare services and the providers that are external to our organisation, and wrap FHIR API facades around those existing systems of record, or indeed translate the data within them to FHIR formats that are compatible with the new national standards. Now, that's a lot of upfront effort before the rubber really starts to hit the road here, because what that then starts to enable is the ability to provide nimble systems of engagement. These are modern applications that run on all the devices that we love to use, and that can plug and play to a far greater extent than has previously been possible by utilising FHIR against our platform of exchange and by being launched from our systems of record using a protocol called Smart Launch. And skipping over to systems of insight, which are AI and automation and big data and analytics are massive advantages as we go forward in the next digital age. They will benefit from being able to rest on a standardized, rich source of data from our platform of exchange that can be converted from our FHIR formats to the SQL formats upon which those data crunching systems rely. So where does Spark come into all of this? Spark is absolutely integral because it drives the clinical engagement and the technical engagement and the consistent and focused narrative that enables us to undertake this long and multi-step journey. And so it began for us by actually joining Spark as SA Health and hosting the first Spark event in Adelaide earlier this year in February, which was a tremendous success. We're moving on to establish the process and technology fundamentals around our people and our ways of working, and to get that trusted fire and clinical terminology service-based platform in place. And then we can start actually populating it with the fire AU core resources that Spark is providing to us in the form of fire implementation guides. And at the end of the first year, what we'll have is actually quite humble in a technology sense. We'll have patients, we'll have our providers, and we'll have our healthcare services all available in a fire platform exchange that are identified by the national identifiers, which can be understood by all of our partners across the healthcare continuum. And that's the foundation upon which we can build in subsequent years to layer on additional richness in our clinical record and transforming that to fire data formats, to being able to begin an ecosystem of smart apps that are ideally suited to their audiences and their purposes and are seamlessly launched alongside of our systems of record, and to ultimately build our way towards the Australian patient summary available to all of our clinicians, all of our researchers, and all of our patients in a secure, easily accessible manner that supports all of our healthcare objectives. I think that's my time. Thanks very much.
Thank you, Mark. It's great to see, and looking at the sentiment from the chat there, it's people really interested in seeing what the realities look like and a little bit under the hood. So thank you for sharing. We'll bring you on in a little bit when we do a bit of a panel around the country with the different jurisdictions. So thank you for your time. Do hang around. As we continue to go around the country, I'm delighted to be joined by Kendall Hockey, who I will bring up with me now from eHealth New South Wales. G'day, Kendall. How are you?
Morning, Peter. I was going to say good afternoon to those of us on the East Coast, but we're not quite there yet. But our WA colleagues are still in the morning, so preferencing that. But
we need it's a global audience here for sure, but certainly interested in what's happening in the fine state of New South Wales. So I'll bring your slides up now, and I'll hand over to you.
Yeah, thanks, Peter, and appreciate you driving the slides. So, look, Kendall Hockey, Director of the Clinical Repositories and Integration Services team within eHealth New South Wales. So it's a big title. Apologies for that. We do a lot of, across the state. And prefacing the fact that we are doing a lot as we speak. With implementation of the single digital patient record across this state, which is an extremely transformative piece of work. Not obviously the technology part, but equally the change management, which is probably the biggest part of that. So next slide, please, Peter. So I'd like to really begin by acknowledging traditional owners of the lands we're all meeting on today and pay my respects to the elders past, present and future. Thank you. Excellent. So I thought I'd talk today about, some really key things that we're doing and have done and are doing in this space, which really comes down to, more of a patient-centric approach of doing what we need to, where applicable, as opposed to sort of building out massive endpoints. And that's really to do with our sort of limitation of, time, effort and resources to do that. And I think, with the movement of obviously the changes in fire and the versioning, keeping everything up to date. And I do feel openly a little bit for our vendors who work in the fire space of being able to sort of be compliant with the versions as we go through, but that's an international situation we have to be across. So next slide, please. So just in context, New South Wales is big. We are, as I said, significant population. We have a $33.5 billion budget annually back a few years ago. That's growing, almost 180,000 staff, and 228 hospitals and 15 local health districts. So they're people we work with very closely. So it's big, and we already run quite a federated model where we have a number of disparate systems that are all running their own PAS EMRs. The STPR program, which I mentioned, is basically bringing all that together. So for the first time, by the final end of that rollout, and similar to obviously the journey that Tasmanian colleagues will go on shortly. This is a big transformation project. So the end state of working with a new partner in that space has offered obviously a lot of bonuses into the future. So we're looking forward to that journey. Next slide, please. So again, it's important to sort of reflect about what we do, being part of eHealth. We don't go it alone. We work very closely with the ministry and our pillars, the local health districts, and it's very closely as well with the STPRIA that was set up by our secretary to essentially enable this to occur and this transformation across the state. So it is lots of collaboration in making all these things happen. Thanks, Peter. Next, please. So I think it's really important, talking about how we do things across the state. And this is, I guess, a reference to some work that we did, getting involved in fire some time ago, but still very relevant. We have to make sure that we align and adapt accordingly. So when I say align, it's about the standards that exist, both locally and globally, and how they obviously apply. I think the benefits that we look to, I was watching Peter before about the whole idea about standards are sexy. I think standards can be sexy because it makes your life a whole lot easier. I think, all the plumbing we've done historically to make things work in a consistent way because of how flexible our HL7 processes can be from a data within it componentry, makes your life a lot harder to adapt, transform, and that's a lot of legwork. Going into the future, just doing that from a patient point of view makes it a lot cleaner, a lot simpler, and really drives a lot of efficiencies that we haven't seen before. And I think, as I mentioned, is what we've done here really focuses on our patient care. So we're putting patients at the first component about why we're doing this, the benefits to make that happen is available to do it for us. Obviously, there's discussion about using a fire common interfaces. Our approach is we want to build things once, consume many. The use of the Onto servers and the like is also really important. So as we've modernised our integration platform accordingly, we're basically going where like an API first or fire capable. So a lot of the work we do now in the last number of years has all been API driven and used fire where appropriate. So fire is really the go-to. What we do, we are going through, as I said, a massive transformation across the state. It's not an easy piece of work. We have to keep the wheels turning while we transform. That's a significant challenge, but it's something we have to work through and despite the bullet and proceed. Next slide, please, Peter. So this is, I guess, a very summary of what we're doing at the moment. This is not a full extensive list, but it's basically making sure that we create the relevant profiles that we go through to do this. The value sets of codes, as I said, the mapping, like every jurisdiction across the country, we all have different nuances about how things are aligned. I think modernising our old platforms, I think, is the reality of the fact that we haven't always been able to, embed, like the use of IHIs is a great example. Not every system we have historically has the capability to do that. That poses a challenge of how we do it. However, as we embark on this new journey, that's, I guess, a key part of that approach, given that we'll have one system across the entire state. We will have IHIs and the relevant identifiers for patients that we need to go through. So this is exciting times. Next slide, please. So really for us, this is three great examples of what we've done. So ITOC, as we called it, and I think John Lambert might recall this a bit from his days with Civil Health, is about how do we transfer information between two systems, between ICU and EMR. That uses a whole swag of fire services, including an Onto server. Our Engage Outpatients program, which is currently in use, has over 100,000 digital referrers from over 300 clinics across the state, and that's across 17 hospitals and obviously the 7 local health districts. So small part of our entire footprint, but very much away from getting the word of axing the facts, which is something we all want to do. Again, patient-reported measures, or HOPE as it's known, really understands that clinicians understanding the needs of patients and it being able to react accordingly. So all great examples of how fire integrations have made that feasible and aligning to all the work that's been done nationally through Sparked. Next slide. So that's the end of my talk. So happy to take any questions offline, and thank you for listening.
Amazing, Kendall. Thank you so much for sharing, and that sentiment is certainly shared by the chat too. So I'll leave you in the little green room while we continue to go around the country. Thank you so much. In my little tour of Australia, the next state on my list is Tasmania. The man, Dr. John Lambert. It's great to be able to see you get now feet firmly planted under the desk there in Tasmania. Really looking forward to hearing your perspectives today.
Thanks, Peter. Although after 13 weeks, I don't know, I feel like the tips of my toes are under the desk, but there's a long way before the knees get under. And of course, in typical John Lambert fashion, I'm going to do something that'll probably crash the entire system and frustrate Peter with no notice, because I don't have a presentation, as he pointed out, but that doesn't mean I'm not going to present something. Peter's already looking worried. I love it. Well, the problem is the information I wanted to share isn't in a PowerPoint. It's in a PDF that I love zooming in and moving around. But look, the perspective I wanted to give this particular symposium is that from an organisation certainly as large as a jurisdiction, and I'm kind of speaking a little bit of a merge of my experience in New South Wales and of course working with Kendall. Thanks, great to see you again. And also Northern Territory and now Tasmania. There's been an evolution of thinking across all those areas. But to us, fire is not the whole story. So to give you a perspective of what I mean by that, I'm going to hopefully, if this works, share a screen. And the initial screen share is quite a small, I don't know what I have to do to actually activate that. Oh, good, it's turned up. Excellent. And
I have to press a button, but yes,
you're not supposed to read the words just yet. But look, just to give you a perspective that fire is about interoperability. Interoperability is about useful sharing of information about patients for all the stakeholders in their care. And I don't need to repeat what others have said about the complexity of the Australian ecosystem. We're more complex than the US and most of Europe and many other areas. But we have our own systems to deal with inside Tasmania, and we have an interoperability issue inside Tasmania. In fact, every jurisdiction I've worked in has an interoperability issue between a multitude of internal systems. That's in the grey section. We then have what is, in my opinion, likely to be hundreds, if not thousands, of systems that will operate in the interoperability space, whether it's an external practice management system, whether it's the My Health Record, whether it's a billion apps and other solutions that people might think of. We have, sorry, I'm pressing the button on the wrong screen here. I've got a list here of probably about 25 different solutions that we might need to support, and that's just the beginning. So massive complexity in there. So to support the interoperability between all these systems, we need a whole bunch of different capabilities. We need some data repositories and reference data sets for our organizations. We need a bunch of services, and we need some administrative tools to manage them centrally. Now, these requirements are actually no different to a small organization. They just get a little bit more complex when the numbers add up in a large organization. But the point I wanted to make is that fire sits about here. It's sort of to do with content transport. There's some notification capabilities. There's certainly some content standardization and normalization in it. So 3 services out of 35 separate things that a jurisdiction would have to build and deal with to do this job well. Okay, so just those ones in there. So I guess that was the first message I wanted to state, that I love fire. I've been involved in HL7. I've written HL7 messaging solutions 30 years ago. I love the community mentality that Graham and others have created. I love the leadership shown by the Commonwealth in supporting Sparked and Kate's energy and passion that's making it front of mind for everybody. And all of that is fantastic. But it's only less than 1/10 of what we have to deal with to make it work. And so right at this moment in Tasmania, a lot of our discussions are, well, how do we create these business directories that actually drive fire? I mean, I can turn that into a different format, so you don't have to turn your heads on the side, which hopefully makes it a little bit easier to read. But so we don't have a single directory of all the people involved in healthcare in Tasmania. We don't have a robust, centralized, one point of call list of all the locations where we deliver health services in Tasmania. And you could substitute Tasmania for many of the other jurisdictions. When I was in Northern Territory, everything I'm saying about Tasmania applied to Northern Territory. We don't have a structured list of all of the services we offer. And then, of course, we don't have a connection that links them all together. So we don't have a construct which describes all the locations at which we provide each service, which is a link between those 2 databases. We don't know all the people who provide which service at which locations. On top of that, if you're going to use FHIR, you need to know where the endpoints are. And we've used the name digital address, because when you say endpoint, a lot of people think secure messaging systems that already exist. But we need to have a place where we can store all that detail about who we're sending information to and from, what their certificates are, what their permissions are, etc. We need to know which systems we're interoperating with and whether we trust them with certain information or not. We need to have an agreed method of deciding, well, what content are we happy to share with the following consent privileges versus other? So, sharing things like potassium levels. FHIR's got a great resource for that. But we have to decide whether we're happy to share potassium levels under a consent model that is perhaps needs to be different to the consent model for your STI results. So we need to understand the content types so that we can set appropriate privileges around sharing. And then take it further than that. What about the context? Sharing a potassium level that was done inside a jail may inadvertently share the fact that somebody is under the correctional, the justice system in jail. And that may not be something that they're willing to share with the rest of the world. So we may have to treat different contexts. So, a full blood count performed in a sexual health clinic may not be something that you can share, because the fact that it was taken in a sexual health clinic is part of the result. So we might not want to share it. Then there are opportunities around terminology, and people talk about terminology as in clinical terminology, but what about language? From our point of view, we would like to be able to centralize language translation so that if we're presenting results, why shouldn't we present in a patient portal their results in their language rather than our language? So having that coordinated and governed centrally makes sense to a jurisdiction that wants to actually govern and control these, a little bit different to a startup situation. And so on. There's more detail there. And then the final issue that we still haven't really resolved, and FHIR definitely supports consent models, but we have to work out what type of consent models we want to support and how we record that and how we register that. And should that be recorded at a jurisdictional level, or should that be recorded at a national level? So some of the work that we're doing here in Tasmania, and most of you are probably aware that we have this thing called the Blue Gum Health Transformation, which is intended to reshape the way we deliver healthcare in Tasmania so that we can cope with the massive onslaught of workload and complexity that's heading our way. A focus on preventative care, a focus on consumers, a focus on all of the health that is delivered outside this jurisdiction. So one of the things I feel is that jurisdictions have to stop regarding themselves as the most important player in the room. We deal with patients less than 1% of their life, if you're lucky. Probably less than 0.5% of most people's lives is spent in a facility run by a jurisdiction. So we have to focus on the 99.5% of healthcare that is managed outside our walls. And so I think that's a key driver that is very aligned in the Blue Gum Health Transformation Program, because the strategy that drives our program of work is very much focused there. But to do that, we need that interoperability. We need that diagram I just said to come to life. It's hard work. I can't promise that we're going to be successful, but FHIR is, of course, a critical part of it. But I have about 10 times as much work to do on top of FHIR to make it all come to life. I hope that's sort of been helpful as a bit of an illustration of where we're at in Tasmania. As you've probably seen from recent announcements, we're still negotiating with a potential vendor for an EMR. And this is not stuff that the EMRs generally will do for us. This is outside the EMR. Interoperability generally sits outside, or the EMR is just one of our internal systems we have to interoperate with. And so interestingly, the most EMR vendors have a bit of an EMR centric view of the world, but unfortunately that's not the way healthcare is delivered in Australia. What do I do now, Pete? Do you just come in, or do I have to throw to you? Or do I have to keep chatting on my own? I think I'm still connected. Have I done something to keep Peter out?
Sorry,
oh, no,
John,
he is.
I would... No. It was a me thing. My internet, and I was listening in diligently, and my internet started wigging out, which is not great.
Oh, no.
We'll get there.
Because I thought surely he's not going to hold it against me that I finished 1 minute early. That's a rare thing for
No,
John.
not at all. I was clicking things and we got there. No, look, John, I really appreciate that. It's great timing as well to have you in this discussion with all those things going on, as you say, and we're kind of in the thick of it right now. So we'll continue on our journey around the country and hear from other jurisdictions. Yes, we will. Thank you. Next up, I'm going to bring onto the stage, we've got dual presenters from Western Australia. Thank you, Jeff and Frank, for joining us today.
Thanks, Peter.
Amazing. Let me just
Thank you
pull
very
up
much.
those slides as well for you, and looking forward to your presentation.
Thanks, Peter.
Over to you.
Thanks. We'll do a bit of a double act. I'll lead off and then Jeff will kick in. So if we could have the next slide, please, Peter. Great. So we've been involved with Spark since the start, and it's been a huge thing for WA. And one of the things has been trying to establish our fire capability, including all the required infrastructure. So we seized an opportunity that was presented through the interoperability program through the Digital Health Agency and developed a proposal which was supported by the ADHA, and we do thank them for that. What we wanted to do was develop our fire capability and repository by, getting the required infrastructure, service cores set up, configuration, and all the processor licensing set up. It's been a lot of work in a short time frame, pretty resource intensive, and but we do hope to have all that established by 30th of June this year. So we're pretty excited about that because we want to be in a position to be a lead on implementation of be it e-requesting, shared patient summary, as already being fire enabled. Next slide, please. So when it comes to standards, look, WA has always been very standards based. Going back prior to the ADHA, when we had NETA, we jumped on board early with any standards that were developed and implemented them as best we could. It's fair to say we got some pushback in the early days when everyone wasn't really on board with standards, but persevered as we figured it was the way to go and way of the future. So structured data and standards are well embedded in our systems and applications here. But we've been collecting SNOMED codes and discharge summaries for admitted patients as well as emergency patients. And then the coders are still doing ICD coding. In fact, I've got over 10 years of quality coded data. We're fortunate that we've had a statewide identifier for many years here, and that's made life a bit easier. Standards with identifiers using identifiers through all the health identifier work. And that's what enabled us a couple of years ago to roll out e-prescribing statewide, and that's been a real benefit for us. We don't have an EMR, and we're only at the start of that journey. We have an EOI which only recently closed, but despite that, we do have good interoperability with the systems we do have. Next one. So looking at some of the benefits we figure with progressing it on our fire path, being able to get faster integration with the other agencies we work with. We work with St John's Ambulance Service, RFDS, Aboriginal Medical Service, Residential Care Lines, WA Police, Silver Chain, who provide care in the community, and aged care providers. So we wanted to be able to progress that, and they can now join in via VCC to issue patient referrals to a system we have, which further down there, the WA Virtual ED. Now that's we're at the start of that. That's been rolled out recently to do that virtual care. And that'll be followed by enablement of some paediatric pathways and referrals from Health Direct in July. On the supporting virtual care, as I said, we recently launched that WA Virtual ED, and there's a range of services we currently deliver from that, but there's a heap more we want to expand on. Also do work with virtual aged care and acute patient transfer coordination services as part of through our state health operations centre, which is like a command centre for the system. Next one. So also, like, implementing new services is so much slicker and quicker when it's standards based, and fundamental for that is interoperability, which we've always had a big focus on, and people like our Chief Clinical Information Officer Peter Sprill is a big driver and pusher of that. We want to be able to get faster development of consumer-facing services, consumer portal platforms, virtual front doors, not just at a state level, but figure like that should be progressed up to a national level. And when it comes to external providers facing services and portals, that supports referrals and supports data exchange both across public, private, primary, acute sectors, allied health, and the list goes on. So we see some real benefits and are keen to progress these as quickly as we can. And I'll now pass to Jeff for the next couple.
Cool. So hopefully you can all hear me. So Frank's given us the blurb, and I'll point out, if you can just go to that next slide, thanks, which is fine. I'll point out the typo in this first slide in the top bit where it just says either fire repositories. That was meant to read fire resources and bundles, as required determined. So where we're at the moment is we have a large use of APIs underpinning a lot of our integration to both bespoke apps and with our partners, both internal and external. And we want to add fire to that bow, as I'd call it. And like I said, it's not a complete replacement, but it's an extension of our capability. So all about our fire implementation adoption at the moment is to be able to add fire to that bow, because we've had our clinical information model for a long time, which is very closely aligned with the fire data models. We'd like to think that we've jam-packed those data models with a little bit more information over the years than what's in fire, but it's maturing quite nicely to come along and into alignment for us. So our aim at the moment is to stand up a couple of fire servers alongside our current InterSystems Iris technical stack to allow us to go, develop further in terms of fire API resources alongside our REST APIs and older SOAP APIs. Now, we are closely aligned with fire terminology value sets, and our aim is to continue that sort of moving forward. And we have a lot of internal consumers in our health support providers or HSPs like East Metro Health Service who can't wait for us to enable fire resources for them to consume for some of their virtualized care models, which is where a lot of our work is going. We've also been very interested in the introducing agnostic e-requesting to our sort of environment, because in the country health service, whilst in Metro we can closely control, where people take their requests to, because it's mostly hospital based. In the country, patients turn left or they turn right, and they'll go to, any one of diagnostic or pathology service providers. So we're very interested in making our requesting for pathology and diagnostics, diagnostic services or diagnostic imaging agnostic, so that we can both get it out to and then get the data back into our systems to display it. Because there's a mixture of public and private servicing, we need to be able to both request and consume the results on both sides of the fence. So we equally have our discharge summaries where we're trying to put that e-requesting into an e-result application that we're currently sort of rolling out into our discharge summary system to help the doctors summarize their results. It's not quite what we'll call AI, but it's I'll call it augmented intelligence rather than artificial intelligence to allow them to summarize the data. And that's a bit of work we're doing at the moment. If we go to the last slide, I'll just jump straight into the depth of it. On the left-hand side, which is what we'll call it on our side, the left-hand side, that sort of represents our current stack, which is doing everything. That we have a number of read and write APIs that come off that stack to service a lot of our internally or bespoke applications. They're also used to service external providers in terms of patient and episode and medication, script, allergy, adverse reaction data. But what we're doing now is we're extending it out. So over on the right-hand side, we're adding in 2 FHIR repositories, and they're repositories / facades because of the quality of the data that we've got. We're assuming that a lot of our FHIR resources that we store may equally be, end up being bundles of resources. So we're trying to get the best of both worlds by saying, yes, we'll have a FHIR repository, but we'll also have a FHIR facade. And we're trying to set it up that we basically, what I call, write from the left-hand side and read from the right-hand side. And we're trying to leverage as much as we can around the intersystems enterprise cache protocol channels, such that we've got the one active data store that's then exposed out to our FHIR repositories to bring the data back. And by going down the intersystems model, we're able to have different versions of the Iris platform in place. Our overall aim is to get them all on the one version, but we've set it up deliberately such that we can put in new versions of the Iris platform that'll expose us to newer releases of the FHIR data models without having to upgrade the entire stack. So we've made them deliberately agnostic from each other, so that the left-hand side and the right-hand side are complementary, but they don't have to be tied completely in step. So that's sort of what we're doing at the moment. It's an oversimplification of the data models and all the work we've done in the past underneath it. But the FHIR journey we've got at the moment is that we're really at what I'll call the pointy end of putting the actual FHIR servers in place with an API manager around it, because we have a lot of people who want to start using FHIR, and we really want to get involved in the e-requesting, the AU summary space. So we're just making sure that we've got the capability in place to keep that journey going. So I'll stop there and we can move forward in whatever we're doing today.
Amazing. No, look, thank you. It's great again to see examples, and the commentary in the chat is certainly complimentary of the approach. And as people mentioned, Western Australia is no stranger to virtual care approaches. So let's bring all of the participants onto the stage so we can have a bit of a panel session. I think we got everyone. And we got a bonus participant as well, the one and only Raylene Donovan from Queensland. How are you?
I'm very well. Thanks very much, Pete.
It's great to have you here in this discussion too. I appreciate you forfeiting the opportunity to present in this rather, whilst it's a huge day, there's only so much time for every state to have their spend time, but it felt like it's important to have you in this discussion here. So I may actually kick off with you, because I can see there's comments and questions come through in the chat, and we'll try and unpack that as much as we can. I know that John and other participants have been in the chat and commenting with replies as well, so we'll do our best to address any particular questions, but really want to focus this conversation up until for the next 35 minutes around the role of jurisdictions, particularly when it comes to standards. But actually, Raylene, it was brought to my attention that at the Sparked launch event in August 2023, Tanya Kelly said that you'll remember this day as the day that digital health changed in Australia. So reflecting on that statement, do you think that there's been a shift, and what do you think that the Spark community has contributed towards that shift?
It's a really great question, and it's always interesting, isn't it, how sometimes you make a comment at different events, and then that's the catchphrase that people grab onto, and then down the track it's actually leveraged. So I think Tanya will be pretty proud in terms of that comment and having it come out today. I definitely think there's been a shift. I think there's always been... I'm actually just going to reflect back. I still remember when I first stepped into this role, it was only meant to be for a couple of weeks, and here I am 2 years later still here. But full everybody was sort of going on about why can't our systems talk to each other, like why we we have to use multiple systems to provide clinical care, and why is it so hard for them to actually link together. And it's really interesting from a clinical perspective because we do have a common language. Like I can move hospitals, I can move departments, I can provide care, and in general most of the terms and conversation, like it's common. Like an ECG is an ECG. We know that we have URNs or MRNs, but like pretty much it's wherever you go it's the same. But when we actually look at our systems, it's not the same. Like we don't have a common language. And so I think really what this, in terms of from the Spark program, I think what it's done is it really sort of has moved us forward to actually start providing that common language. Like what is clinical information? Like what do we see as being core? What creating that standard language, creating that standard structure. And I think what is really important, more important probably about the Sparked program and the Sparked community, is the fact that it's brought together people from the different aspects. And really it does show in terms of if you have a common vision, if you have a common goal and you start working together and collaborate, like if you think about it, we've got health providers from public and private, we've got our industry partners, we've got our academics, we've got government, and we're all actually now working together to solve the big problem. And by doing it, we're actually achieving it. And so I think it's also, I think for the program itself, it's definitely demonstrated in terms of what you can achieve, but it also probably shows, more importantly, that we have a lot of wicked problems in healthcare, and we have a lot of we're all trying beavering away to solve them. But in actual fact, when we actually all work together, you can actually achieve a lot in a very short space of time. So that's I'll stop there.
Love it. Look, it's great to see so many jurisdictions on stage too. And as Kate's pointed out in the chat too, there are other jurisdictions as well that we'd love to have participate. There's only so much we can fit in today. No doubt there'll be future sessions where we can dive into those specifics in a little bit. I'd love to be able to shape this discussion that we have in the remaining time around what's important to participants as well. And I see a question in the chat specifically. It's been directed to John during his presentation, but I feel like there's relevance that everyone can kind of pull out of it as well. I've just pulled it up on the screen. There's these points around consent, and obviously at a jurisdiction level, there's much more direct involvement with a patient. So we need to manage, the state needs and the federal needs, and obviously for the consumer expectations as well. In this world, John, of as we're implementing standards and putting information together, how do you start to go about, the responsibilities at the jurisdiction level when it comes to consent and the consumer requirements, while also trying to meet the needs at a state level, and then we've got to tie it in with federal too? Like, what's your thinking around pulling those different important parts together?
Well, I think the key message is that this is quite a long journey. Okay, so we've had, decades of attempts just to do interoperability, which is kind of simple compared to consent in some respects. And I'm filled with hope because the private sector have shown us how consent really can be managed. If you look at LinkedIn, Facebook, the ability to control who sees things you post, even to control who posts things about you. You can set privileges on whether you let people tag your name in photos and things like that, right? So the technology has come an awful long way since 2015, when I remember being involved in some jurisdictional discussions about this. So, and I think the key is, as leaders and jurisdictions, should they be leaders? I mean, there's only 8 of us, but we do have an outsized weighting in a lot of the conversations. And I'm often in jurisdictional meetings saying, yeah, but we don't represent private sector medicine, which is where the bulk of care is delivered. We don't represent primary care. We don't represent aged care. We don't represent private hospitals and allied health practitioners. But we do have a fair voice, and we directly connect with the federal government. So I think the leadership we have to show is to say, we're keen to address this. We're keen to allow consumers to have a say in where their information goes. Because you've got to remember, in the paper world, consent is kind of implied, because I go to a practice, I know they're writing my notes on a piece of paper. I know that piece of paper generally stays inside the practice. So implied in my attending that clinic is that they're the only people who are going to see my information. So as soon as we start doing this national sharing and connect everything where every information is going everywhere, it's all absolutely wonderful. As a clinician, I think it's bloody amazing. But it also requires a much higher level of responsibility on us to constrain that information where it's appropriate to constrain it. Now, the opt-out rate of the My Health record still sits at around, I believe, around 9%. My feeling is it's because we don't allow patients enough control over their information. And the My Health record is one of the best systems. It has probably the most granular consent model at document level of any of the systems out there. But I think we need to do better, because all I see are edge cases. And like numerically, each edge case, each unique population of patients that want something special for consent is small. But when you add them all up, it's about 10% of the population, the people with unique needs, the people who don't want their information shared, you know. So I think our job is to recognise that, respect the wishes of the consumers, aim to build something that will meet their needs. We're not going to be able to do it next year. We're not going to be able to do it in 5 years, in my opinion, but we should aim to be doing it in the next 10 to 20 years.
Yeah. No, thank you, John. I feel like that rounds out that point quite well. I did want to go to other states and jurisdictions to get their perspectives, be it on consent, but also Mark, I might go to you, who opened up these sessions, just to think, you know, specifically around, you know, this is where the rubber hits the road, I guess, in the jurisdictions and the implementation of standards, and you've got a responsibility there to be able to, you know, I guess align with what's required, but also meet the needs of consumers and clinicians. How do you think about the role of jurisdictions in making sure these standards are adopted and taking into consideration all those points that we've talked about already with consent and whatnot?
Thanks, Peter. Interoperability is a team sport, and the jurisdictions have a role to play in being, as John mentioned, leaders with an outsized voice in terms of the representation of healthcare, in bringing the team together, in accepting that there are different ways of doing things. You know, each jurisdiction is going to have its own unique flavour of applying the standards and achieving the clinical objectives and the improved clinician and patient experiences that we all want. So that takes time. It takes being opinionated and being willing to accept criticism. And so out of that comes the agreement. And it's not always, you know, unanimous consensus, right? That consensus is derived through hard yards at clinical design groups and at technical design groups and at multiple iterations where we keep coming back to the same problems. But unless the jurisdictions participate in the team, we all play our respective roles on the forward line and the back line and up the middle, and we focus on the same goals. Then we will solve problems like sharing the basic administrative concepts of patients and services and appointments. We will solve the problems of assembling a comprehensive Australian clinical patient summary and having that available to everyone all the time, and in not sharing it when it's inappropriate to do so, you know, where there's domestic violence situations, where there's custodial disputes over children, where it involves sexual health, and many other edge cases as well. And so all of those safeguards do need to be built in. They're complex conversations, and this is the unique advantage of Spark, as it provides that room, that space to have those conversations, to have those differing viewpoints, and to find a way forward that we can all live with.
Yeah, and I guess staying on that point around, you know, finding some consistency that and alignment there, you know, whilst there's alignment in terms of, you know, there's 8 jurisdictions, every jurisdiction is quite unique in terms of its demographics, its tech stacks, its required, like everything. If I was to go to New South Wales, Kendall, and look at, you know, thinking about the role of Sparked and the thinking about, you know, at a hospital level implementing these types of initiatives and standards, what's the role, like, as New South Wales being obviously a larger state and different challenges and requirements, what's your thinking around this particular topic?
Look, I think we're all in the same boat. I guess the biggest thing here is, I think, and John touched on it, is that we want to we have a small part to play in patient care. Let's just be frank, right? We want to keep people out of hospital. So I think the outcome we should think about is how do we actually improve health outcomes with what Spark can do and offer. And I think the work around aged care is a great example of that. That's a challenging space. But I think it's what we can do and leverage as a group. So when I say that, we all want to do the same thing. And I've said this, I think, in past meetings. I think at Spark 2, which is 2 years ago, it's hard to believe time's gone so fast, is that we should be always looking to say, okay, well, who's doing what? Who's going to build out a certain fire API that we can leverage and say, well, New South Wales will build one thing, South A will build something else. So we actually all contribute together. So we're not sort of all doing the same thing, because I think it's fair to say we're all under immense pressures for time, resources, and funding. We can't do everything, but I think we really have to focus on what's important that really has an outcome-driven component. Like I was at a meeting, in fact, when we implement Epic across the state, we'll be the world's largest customer. It's like, well, really, technically, that's wonderful, but unless it has actually significant patient outcomes, the question is why. We've got to really focus on keeping people, I think, to be fair, out of hospital where we can. So I think, how do we share relevant information where appropriate? And I think the whole, primary care networks, allied health is a great example. Those other areas are really the ones we should be working closely with to say, well, okay, what is it that you need to make your life easier that we don't do today? So I think we've got to step back a little bit of all the raft of things we can do. And Spark, I guess, is the enabler to make it happen, that we're all on the same page. We've got to have that sort of North Star focus of how do we use all the stacks available to us to actually make an outcome difference.
Yeah, absolutely. And if I was to look, on the western side of the country, and to WA, I noticed during the session, Frank and Jeff, that there was a lot of comments from participants around how Western Australia's SNOMED coded discharge summaries are like the gold standard in Grant's perspective, and that was well emojied. That's become my term now of what the chat deems as appropriate to discuss too. And I love the point that Chris made in the chat too, that I feel like this is a sentence that kept getting more interesting as well, about how back in when he was doing wax emergency telehealth shifts while I was in Iceland. But anyway, that's another story for another day. Back in 2018, that Western Australia has really been an early adopter and a leader. I'd be curious to hear from you while we've got it here, given that you've heard all of the different jurisdictions and you talked about the nuances in WA as well. I'll let you work out who's probably better placed to mention. But if there's perhaps some unique learnings or something that other states can take from the WA approach, what's relevant to other parts, or maybe what's just unique to WA that's going to stay quite WA centric? I can pick one of you, but
So I'll jump in for a quick one, Frank.
Yes,
So look, I think the telehealth example was a good one because of our adoption of health identifiers, which enabled us to do the e-prescribing, right, better work. Now that was a main enabler also of that virtualized care, because those same telehealth clinicians that says, yes, I was able to come in and remotely manage a patient. The e-prescribing work that we did also enabled those same telehealth clinicians to be able to prescribe a medication. Sorry, someone was just showing me a picture of earlier, and they're very Farby-esque. Frank will know who I'm talking about now. But
love a live event, but that's okay.
That's my event, but yeah, that was our CCI, our CIO, who was actually showing me that, so I had to pay him attention. So
he should be
in
joining
terms
the
of
session.
He should be, but well, I'll take that up with him. But anyway, that e-prescribing, the use of health identifiers, that enabled those same remote clinicians around the world to then be able to prescribe or generate a script for someone where we didn't actually have a physical script having to change hands. That same functionality will then come with e-requesting, that they could then also order pathology, they could order x-rays, etc., from that, follow the sun support of our population as we do it. Look, I'll hit on the same thing. We are forensically examining the consent data model that's within FHIR for use of adopting that to equally implement as a central repository of consent for the different things. Now, whether it be patient limiting access to sensitive data in sensitive situations, or to using health identifiers and authorization to enable us to know that clinician Bob, who may be in Iceland or whatever, providing support, really is clinician Bob, and what roles and access should he have in our systems. You know, our aim is to provide the clinical teams that we can accurately identify with all of the relevant information to help them treat those patients that they're trying to do, you know, both in a virtualized care model where we're trying to keep people at home rather than admit them. But it comes with all those requirements about being able to both have an authorization store, an API management to say that we only expose them to the data that they want, or we give them as much data as they need to make that clinical decision. You know, it's nice to have SNOMED terminology, you know, encoding our discharge summary data, but there's also the subtle nuances around not all doctors like the preferred term that SNOMED produces. So we've had to implement not just preferred terms, but the, you know, acceptable acronyms for those terms so that they can record the term that makes most sense to them. And that was part of some of the earlier chat that we had. Enforcing data sets also has to have relevance to the clinical teams and not change the context of that clinical information, which is one of the challenges that, you know, I look at FHIR data models as being a little bit of what I'll call a hyper-normalization of data sets, but we've also got to maintain their utility to those people who are providing the care, and that the way we record the data doesn't change the clinical context in which it was actually captured, right, and then represented. My data has to travel backwards and forwards between different people without it changing the clinical context of that data. And the terminology basis and the classification models and the data sets shouldn't be putting that maintenance of clinical contents at risk. So look, it's a wonderful conversation to be having. You know, we're having a conversation about what we can do, not about what we could do. And that's a very good place to be.
Love that. Look, if I think about, you know, how best to make the most of the time with everyone on the screen today, and being, you know, such a vast community of different stakeholders at different levels of experience, I'd love to actually put to each of you for perhaps a couple of minutes for us to close, given we've got about 15 minutes, 5 representation. Yeah, that's right. So the I'd love to know what support you need, what support jurisdictions need in order for this to continue to be a success, or like build on some of the success we've had, or at least the opportunity that presents. I might start with Ray. Would love to hear from you. What support do jurisdictions need to, I guess, implement these standards that underpin all this connected care for consumers?
I really wish you didn't start with me, but that's okay.
We don't have to. Like, we could come back to you after.
No, it's fine. I think in terms of what's been the progress today has been really good, and I'm probably really wanting to make sure that we maintain the momentum. And then it's really ensuring like what is required longer term also is probably thinking about it in terms of how do you, like, we're doing this body of work, which is great. We're going to work out how to implement it. We've obviously got challenges we've got to overcome. You know, we've got funding issues, we've got resource issues, at which again it's all been come out in the session this morning. But probably one of the things that comes to my mind is how do you maintain it? Like, how do we where does that sit? How is that funded? Like, because as I said, it's not something that you set and forget. We definitely know it's obviously got an ongoing investment that's needed. There's work effort that's needed to make sure that everything's still contemporary. Like, what's the governance model? So really, like, what's the longer trajectory for this to make sure that we continue to actually be able to support what we actually need to have this going forward. So that's probably one thing that's front of mind to me is the longer term plan around this.
Yeah, 100%. That makes a lot of sense. I'm going to go around to New South Wales now. Kendall, any thoughts from you?
Yeah, look, it's a really good question, but I think it comes down to, look, we all have different priorities that we're working through, and is, you know, the alignment of what we'd like to work on versus what we actually can, just purely from a time and effort perspective. This is always the balance, I guess, hence my question of, you know, as a collective, what do we see is important to improve, I guess, our patient care, and that's the sort of feedback component. And I think that's the whole idea of we can do lots of things, but what's the best value for us to agree to? Because we just don't have the luxury of enough people. We can, I think, all admit that. I think from a healthcare point of view, we're all struggling with, ongoing cost challenges, staffing, et cetera. So I think we have to work out as a group what is the real critical, important stuff that's going to make a difference.
Nice one. I like that. And really touching on some of those key issues. What about in South Australia, Mark?
Thanks, Peter. Look, I think firstly I want to shout out for the Australian Digital Health Agency that the funding and the leadership at a Commonwealth level has been instrumental in getting us where we've gotten to on interoperability to date in South Australia and where we're going to go. So, the national roadmap through to 2028, it makes it a priority, and the funding support as well as the regulatory requirements that follow behind them really do help us achieve the interoperability gains that we all recognise that need to be made. For all of us as jurisdictions, I think demonstrating cross-jurisdictional initiatives that are data supported will be great. Everyone loves a good story of benefits realisation, and so jurisdictions banding together, winning executive decision-making support really helps drive that narrative. And I think influencing our vendors. There aren't that many vendors and solutions in the marketplace. And if I hark back to David Rowland's paper for the agency back in 2020, requiring our vendors to meet the minimum bar of interoperability, to get along to HL7 connectathons and test their solutions. From my own perspective, particularly against the smart launch track, those are things that will really provide the evidence base that shows that interoperability works.
No, I like that too. That's a great message and something we can all apply. I'd love to hear from WA. Maybe Frank, if you've got any reflections.
I can jump in there, but yeah, look, I think it's been amazing the foundational work that's been put in place. I think the drive and support from the Commonwealth in leading and supporting at a senior level, has been instrumental in this, and the resourcing through Commonwealth and ADHA. We need to, the next focus is what are the next steps? What are the next steps? I know we've got the roadmap and that, but where are we going to get the best bang for the buck? Who are we missing? We've got unprecedented stakeholder engagement, so let's not lose that. It's a unique time we've finally reached, where many years interoperability was only ever talked about. I could go back 10 or 15 years where it was talked about, but we're really starting the rubber's hitting the road now. So I think we need to look at the pennies finally dropped, and we need to work together, because there will be significant, otherwise there will be, continue to be significant barriers. And I think that it's really important that we leverage off what each other's doing, minimize reinventing the wheel. We all work in our own jurisdiction, we're doing stuff. We need to keep that collaboration going so that we're not five of us working on the same thing that we could have done far more efficiently. And I think what's helping is the level of engagement at a senior level. We had a senior rep from WA come back from a national forum saying we need to get on board with this fire stuff, and we were lucky to say, well, look, here's one we prepared earlier, we're onto it. And good stuff. So I think it's good that it's getting that airtime and that sort of thing. But yeah, we need to make sure we're not leaving anyone behind. We don't want to have 5 sectors all on board going great, and then we've got one over here that has been left out for whatever reason. We need to bring them all along. So that's probably my take on it.
Yeah, love that as well. Look, it's a challenge, isn't it? And but getting that alignment is critical. John, I know thank you for being so busy in the chat, by the way. You're making my job a little bit easier and I'm sure participants are getting additional value from what's happening there. I'd love to hear from you, because you've obviously seen a bit in different states and obviously where you're at now in terms of what jurisdictions really need now, and I'm happy to build on it onto any other final thoughts and reflections as well.
Yeah, look, a lot of what I would say echoes what Frank has just said, but it's really about staying the distance. This is really hard stuff. I didn't mention that one of the things Tasmania's doing is contributing to the development of the provider directory, the National Provider Directory. We've been trying to build national provider directories for 20 years. So it's really important we try to get it right, but don't think it's easy. I mean, I agree with Frank to have all the jurisdictions collect together and build something once rather than 8 versions of the same thing is definitely the right thing to do. But geez, that's easy to say. To get 8 jurisdictions with all of our different forces and masters and legislations to do something the same way, it's really, really hard work. It's worth it because we get a much better outcome, but it takes longer. Like Frank, I've been really, really happy to see how everybody is pulling together. The language, the conversations at the national level, I've been involved in for 10 years plus. And the quality and openness to share, the openness to do things together, the keenness to work together, you know, you can be cynical and say, well, it's driven because nobody can afford to do this stuff. Okay, but it is a wonderful environment. And I just hope that that continues. That's the most important thing. We've all got to want to do this. We've got to want to do it together and keep sticking with it because it's not going to happen quickly. And to those who talk about funding, there's never going to be enough money. It's all about prioritizing where you spend the money. And that's where, again, I would say we've got to keep focusing on where the value is. The value in healthcare is in preventative healthcare, community healthcare, minimizing the impact of chronic illnesses. We're never going to build enough hospital beds to deal with the acute stuff. All we can do is reduce it. And so if we keep that laser focus on that being more important than building acute care systems for inside hospitals, then we might get somewhere. And if we do it all together.
Yeah. Love that. And you called out funding, and it reminded me that Vicky in the chat, pointed out too that governance and ongoing funding are key. Given we do have a couple of minutes left on the chat too, and I want to make sure I get the most out of your time on the screen today. Perhaps if we circle back to anyone on the panel, but I'm not going to throw it out because then no one will answer and then it'll get awkward. But maybe if we do go back to Ray, but I'll explain my question longer so she's got time to reflect. But particularly, we have touched on governance, and we often say that, it's important that we have the governance around it. But I would love to know, from your side too, on how you like the role of the importance of governance, I guess, and what that actually looks like tangibly at a jurisdiction level. When we say, well, we need good governance around the implementation of, these standards to ensure safety, sometimes these feel like statements, and then we point to perhaps, a framework or a document, and then there's reality of clinical work, which I know you see on a regular basis that happens on a day-to-day. How close are we to this governance being the actual guardrails of what needs to happen here, and how important is it to you in Queensland?
Yeah, I'm probably going to, I may not actually answer the question, but probably reflect on something.
It's fine.
When governance is set up well, and when governance actually it actually helps, if that makes sense. So I think frequently we've all experienced when it's not quite set up properly, it's not quite working, and it actually slows everything down. But in actual fact, when you've got good structure, good processes, good governance, it actually helps things move through, and it helps implementations in particularly go well. And so I think that's, to me, it's not meant to be there to hinder or anything like that. It's actually, if we set it up well, it actually will help us monitor, maintain. Again, you don't set and forget. Again, same from what I was saying in terms of developing standards. Governance is the same. You don't set and forget. You've actually got to continually review, update, make sure that you're actually staying up to date and it's actually delivering what you actually need it to do, which is structure, processes, decisions, responsibility, accountability, etc. So I probably haven't answered your question, but it's probably in terms of why, when we do things well, it actually works. And even from like the program point of view, the reason why this has actually worked is because we've all understood the purpose, we've all understood the remit, we're actually all working together, we're actually achieving the outcome that we actually was actually established. So I'm just reflecting in terms of, if we can actually set something up that works, then we'll get the output that we need.
Yeah. Look, Ray, I don't think we could have summarised that any better and close out this discussion. So thank you for those additional insights there. I feel like we've hit time with this marvellous group of jurisdiction community of Sparked. So thank you all the participants for joining in this session today. Oh, that's a short little snippet that gives me only a couple of seconds to get everyone off on screen and ready for the next part. But we are moving into the lunchtime break. Before you run off, we've got a Menti for you. I want to know. I want to know what you think. And so while I just fix that up to come to the next question, just a reminder, you go to menti.com. Maybe you already have it open. I could have got this ready for you here. But the next question on the Menti is, what are the enablers to support the adoption of standards developed by Sparked in Australia? So I believe it's a bit of a word cloud one. Get to work on your thoughts here. It'll be interesting to see how this rolls out through the break. We're going to take about 30 minutes. It's just hitting 1 p.m. Australian Eastern Standard Time where I am, so we'll be back at 1:30. But do keep the page open. As you can tell, we're starting to get more and more into the weeds of, well, not the weeds, but the doing parts and seeing some examples. And after the break, we'll see some really specific examples from the vendor community, and we continue on this session. So do stick around, take a quick break, and put those comments and questions in the Menti, and look forward to seeing you soon.